Welcome to the Ocular Surface Academy podcast, TFOS DEWS 2 edition. Join us as we meet with the researchers behind this landmark international consensus. Each episode will feature practical clinical takeaways. Before we get to today's episode, here's a quick word from our sponsor.
The Cystaine iLux system is a device designed to treat patients with meibomian gland dysfunction, or MGD. It is the leading cause of dry eye. Dry eye is caused by deficiencies in the quantity and quality of meibum or other tear components within the tear film. Around 30 million people are estimated in the United States to suffer from dry eye symptoms. According to a study, 86% of dry eye sufferers are reported to have clinical signs of meibomian gland dysfunction. Healthy meibomian glands produce clear and liquid meibum. Dysfunctional glands produce meibum that is either cloudy or thick and paste-like. In some cases, the glands do not express any meibum when compressed. This may indicate fully blocked, capped, or damaged glands. The Cystaine iLux system allows eye care professionals to target dysfunctional glands and improve signs and symptoms of MGD using localized heat followed by compression therapy. To clear the glands, the eye care professional positions the Cystaine iLux device on the eyelid and applies light-based heat to melt the meibum. Compression of the lids after heat therapy allows the eye care professional to express the unhealthy meibum. When the blockage is cleared from the unhealthy glands and/or clear, healthy meibum is seen on the lid margin. The procedure is complete.
Welcome your host and co-host for today's episode of the Ocular Surface Academy podcast, Dr. Scott Schachter and Dr. Christopher Starr.
Welcome, Dr. Maria Markouli, today. And
Thank you.
Chris Superstar, as always. Thank you. So, Maria, you are in Australia.
I am.
Which is a big country, and I can't recall where you are. Are you at UNSW?
I am, yep. I'm in Sydney at the University of New South Wales. It's a beautiful sunny day, or maybe a bit cloudy, I can't tell, behind me here. Yep, I'm at the University of New South Wales.
And give us a little bit about your background. You're a PhD.
I am. I'm an optometrist by training. I did my undergrad degree here at the University of New South Wales as well. I worked in practice for a while and then came back and worked with the Brian Holden Vision Institute in contact lens clinical trials for about 5 years, and then decided I wanted to take that further. So I did my PhD under the supervision of two greats, or three greats really, Professors Brian Holden and Eric Pappas and Dr. Nerida Cole. And after that, I worked with the Brian Holden group again on their meibomian gland dysfunction project for only about a year. And then I got this position at the School of Optometry and Vision Science as a lecturer, and I'm now an associate professor. So I've been in this role for almost 9 years.
What was your PhD?
My PhD looked at the impact of contact lens wear on the ocular surface that contributes to corneal erosion formation. So basically trying to understand how do contact lenses cause these open wounds that may eventually result in microbial keratitis. So we looked at both extended wear contact lens wearers as well as daily wear contact lens wearers and monitored them over the adaptation period to contact lens wear, because we know that's a period where they're more likely to develop corneal erosions as well as microbial keratitis. So I had patients sleeping in the clinic rooms for many, many, many days.
Wow. Tell us about pathophysiology of dry eye. Let's jump right into the TFOS DEWS 2 Pathophysiology subcommittee. Were you chair?
No, the committee was chaired by Professor Anthony Bron from Oxford University, and I believe we had about 12 to 15 subcommittee members. I was one of the subcommittee members.
Chris, why don't you lead us off with...
I was going to say, she's chair on the upcoming workshop.
My first time chairing a TFOS subcommittee. I'm really looking forward to that, chairing the nutrition subcommittee one.
Well, I guess we can start with just sort of general questions about the experience on the TFOS DEWS 2 as a committee member. Obviously, you did a good job. They invited you back as a chair, which is impressive. But was that your first TFOS DEWS workshop, or were you on the first one too? You haven't been working long enough to have been on the...
Oh, no, you'd be surprised. I was not on the first DEWS workshop. I was on the CLD workshop that was chaired by Professor Nathan Ephron. So this was my second TFOS, but my first DEWS workshop. Yeah.
And how was the behind the scenes activity on the... Give us the the best gossip from the subcommittee meeting?
Well, I don't think I can really. I don't think there was really gossip as such, but it was a very busy workshop. And of course, we had a range of both clinicians and researchers on the subcommittee that all come along with slightly differing opinions, of course. And that's part of what a consensus workshop is it's coming together with different opinions, but pulling together the evidence in order to understand the pathophysiology of dry eye disease. So it was chaired in a very wonderful manner by Professor Bron, who helped us look at the evidence and put together an understanding of this vicious circle that is dry eye disease. As we started to review that literature, that vicious circle became clearer and clearer. So in terms of what goes on behind the scenes, there's a lot of conversation, there's a lot of drawing, a lot of diagrams, a lot of back and forth on email as well as face-to-face. We were lucky enough to have, I think, 2 or 3 meetings face-to-face.
What were the original goals of the committee? What did you hope to find out or prove or establish?
I think if you have a look at the pathophysiology workshop, it is 73 pages long, and there's over 1,000 references. So it's kind of heavy going. So when we first started to look at this, it was, do we want to just do a fairly light overview of what we think are the underlying mechanisms of dry eye disease, or do we really want to get to the nitty-gritty? And as a committee, we decided that we wanted to first understand the normal healthy ocular surface. So you'll notice that the first third maybe of the document is discussing the normal ocular surface and adnexa, and the remaining talks about how that changes in dry eye disease. So I think the overall goals were to understand in normal and then what happens in the disease state of dry eye disease.
I mean, I'm sure there was a lot of discussion around certain topics and maybe some controversial stuff that people were battling about. But, there was a vicious circle in the original DEWS report, and then there was another vicious circle in the second one. And at first glance, they're kind of similar looking diagrams at the circle and the yellow colors. But there were some differences. And are you able to highlight kind of what changed in those 10 years as far as the pathophysiology, the vicious circle, and the things that feed into it?
I don't think I'd be able to do that very well because I haven't spent too much time looking at the DEWS vicious circle in recent times. Sorry. I know it's a hard question, and I as I was sort of reviewing this subcommittee report before tonight, I was saying the same thing. Just looking at the notes that I originally took, the volume of notes that I took is 5 times bigger than all of the other subcommittees combined. Yeah. It's just, there's so much in there. It's fascinating, but it's very complex. And it goes to show just how much has been done in the last 10 years. These workshops are a really effective way of pulling the literature together and providing advice to both clinicians as well as researchers about what we need to do going forward. So that's just testament to how effective they've been.
Well, it's really the idea of the self-perpetuating or inflammation breeding inflammation, right? That was a part of this committee.
Yeah, exactly. So one of the key points to come out of the pathophysiology workshop was that hyperosmolarity is thought to play a primary role in perpetuating that vicious circle, whether it be as a result of evaporative dry eye disease or whether it be as a result of aqueous deficiency, so not enough aqueous. So regardless of the underlying mechanisms, that hyperosmolarity plays a role. And that then leads to that inflammatory pathway, which leads to ocular surface damage, which then leads to tear film instability, which then further perpetuates that hyperosmolarity. And every factor in this vicious circle now plays a role in the definition of dry eye disease, as well as the diagnostic methodology that was assessed by James Wolfson's team. So I like to think that the pathophysiology workshop was the core workshop because it influenced everything else.
How would you best describe what is a vicious circle to our listeners?
I I would say that with a vicious circle, it'll keep perpetuating and getting worse and worse unless you intervene at some point. So, for example, we know that hyperosmolarity plays a role, inflammation plays a role. So at some point, you'll need to manage inflammation to prevent that from moving on and getting worse and worse. In terms of hyperosmolarity, you'll need to consider using lubricants or managing the underlying aqueous or evaporative dry eye in order to prevent that from propagating. So I don't know if that will make sense to you, especially with the work that you do clinically.
And my takeaway also, there's a lot of entry points into these vicious circles that really drive the prevalence of these patients that we see all day, every day.
Yeah, exactly. I know that we say that hyperosmolarity plays a primary role, but the vicious circle may start with tear film instability due to, for example, if they've had some form of ocular surface surgery that has resulted in tear film instability, and that then results in that self-perpetuation again. So
it's so funny. When I was going to jump in and say from contact lenses, when you said it's all, and you went straight to the surgery. It's funny how ophthalmologists and optometrists think.
Yeah, exactly. Yeah.
But I do find that diagram, maybe of all of the diagrams in the entire TFOS DEWS 1 and 2 reports, is the most, maybe the most important picture in the whole thing. And I give a lot of lectures to residents and people on TFOS DEWS 2, and I spent a lot of time on that diagram because you could spend an hour just looking at that and looking at it because it makes so much sense. It looks very complicated at first and it's a little overwhelming, but it really does make a lot of sense. And Scott, as you were saying, all the entry points, all of what encapsulates ocular surface disease is really represented on that picture, and how each one of those things, from contact lenses to vitamin deficiency to laser vision correction to Sjogren's syndrome to low humidity, blowing air, anterior blepharitis, all of it, systemic medications, aging, androgens, blah, 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 all of those things that we associate with ocular surface disease, it's all on that picture. And it all feeds into that vicious circle in different ways, in different areas. But if you can understand that picture, you can virtually master dry eye.
Yeah. If you look at the epidemiology workshop, Fiona Stapleton's workshop that she headed, a lot of the risk factors that her workshop identified feed into that vicious circle. So it is a very important diagram, as you say, because it summarizes a lot of what was done by the other workshops, but it also contributes to the definition. So in the definition, we now say that inflammation plays a key role, tear film instability plays a key role, neurosensory abnormalities play a key role, and they're all factors that are within the diagram. They're also parameters that we now recommend are measured in order to diagnose dry eye before you subcategorize into aqueous or evaporative. So, yep, it's complicated at first glance, but then when you work through it, not so complicated, I think.
Are kids prone to inflammation at all, do you think? Or is that more of an adult entity with dry eye disease?
I think that definitely inflammation would also play a role in more youth-related dry eye disease, because in dry eye disease, I think, would have a common pathophysiology regardless of age. Although, as we know, age is a major factor in developing meibomian gland dysfunction, for example, and even aqueous deficiency. But I think inflammation, it will still be part of that circle. What do you think, Chris?
I agree. I think it has to be. I think the dry eye ocular surface disease that affects the youth, the kids, is the same. That there may be a different trigger, there may be a different pathway but the vicious circle is the vicious circle, and it's the same for everyone with different.
But it may take more to trigger inflammation in a kid because they may have more aqueous or meibum or something to prevent that.
I think they have more reserve, and so that's why I don't think we see it. The prevalence is not as high in kids, but it's certainly there. But I do think that you're right, that there are mechanisms that the maintenance of homeostasis. There's a lot more reserve in the younger person, and that's why it probably takes a lot more to get there and to get into that vicious circle and initiate it than it does in, say, a 75-year-old.
It does surprise me just how much MGD there is in young people, though. I teach fourth-year optometry students. They're probably 22, 23 years old, and part of what we teach is dry eye assessment, and it's amazing how much dry eye there is in my group of 78 students. I question if the prevalence is more than 50% there.
Yeah, have you seen gland changes in kids versus just a baseline where not all the glands are there, but you've seen glands actually show signs of progression of gland loss in younger patients?
I don't assess many children, to be honest, so I wouldn't be able to answer that from clinical experience. And also, even from the patients that we have seen as part of our dry eye clinic, I can't say that I've seen my Meibomian glands drop out over the observation period that we've had. I think that's a much more chronic change that we haven't been able to capture so far. So I'm not able to answer that directly.
Well, I would say, I don't see kids either, but I've read the literature, and we're certainly hearing a lot more about this. And when you start thinking about risk factors for ocular surface disease, MGD, dry eye, kids are exposed to a lot of the same risk factors that we are. They're spending infinite amounts of time on the computer these days, which, as we know, computer vision syndrome and the effect of staring and not blinking and all that has an effect. And, as a father of two young girls, 11 and 13, I see what they're putting on their eyes, these cosmetics and this makeup and the amount of product that enters their lid margin on a day-to-day basis. That's not good. And I know what that's doing to their Meibomian glands. And then things like Accutane and, pimple medicine. There are a lot of triggers and a lot of risk factors that kids have been exposed to for decades. But we're just finally, I think, now starting to recognize what those things are. And hopefully we can prevent this generation from ending up with horrific, dry eye in their 40s and 50s.
I think this coming TFOS workshop, the lifestyle epidemic workshop, is going to be critical to providing guidance both clinically and in the research setting when it comes to that. So watch this space.
Well, not to mention also antihistamines, ADD, ADHD meds, and all those things that can cause that.
Yeah.
So can you tell us, Maria, in relative to sort of layman's terms, once osmolarity is high, what happens next to trigger inflammation?
Okay, so again, just working through that vicious circle that we've been talking about repeatedly. So with hyperosmolarity, that can result from either evaporative or aqueous deficiency. So with aqueous deficiency, you've got a reduced volume, so you've got an increased concentration of salts in the tear film. With evaporative dry eye, you've got evaporation. So again, that comes down to reduced volume, again, resulting in an increase in salts in the tear film. And that has been shown to trigger an inflammatory cascade within the cells of the ocular surface, within epithelial cells. That inflammatory cascade, so those inflammatory cells within the tear film can cause both direct damage to the ocular surface, as well as cause subsequent damage to goblet cell density, for example. So you have a reduction in goblet cells, which produce mucin within the ocular surface, as well as ocular corneal staining, which we evaluate with fluorescein and lissamine green. That then leads to the tear film instability. So what we see is tear film breakup time, a faster tear breakup time, less than 10 seconds. And that can be because you've got that irregular surface because of corneal and conjunctival staining, or because you've got a reduction in mucins, reduction in lipids, reduction in aqueous. That then further leads into that hyperosmolarity. So that just keeps propagating, I hope that makes sense.
It does. Well done. That's not easy to do. Thank you. So let me ask you the controversial question. Is it 2 or 3 layer tear film? And why does it matter if it's one or another? What does it matter to practitioners? Tell me your thoughts on that.
Okay, so we're entering Mark Wilcox territory. So
I know we are. We talked to him.
Yeah. He's in the office next door, actually.
Is that right?
Yes. So the classic diagrams that we'll see will have those 3 distinct layers, lipid, aqueous, and mucins. But given how hydrophilic mucins are, it's really hard to imagine that they will just stick to the individual layer. The thinking now is that they are interspersed within the aqueous layer as well. So you do have more like a graduated transition between especially aqueous and mucin layers. Why does it matter? It matters because if we have an inadequate mucin layer, for example, even if we've got the best aqueous and lipid layers, so even if we measure, for example, the LipiView, we use a LipiView in our dry eye clinic to measure lipid layer thickness. We're fortunate to have it. So even if you measure a nice thick lipid layer and you use a red thread and you measure a nice or Schirmer strip and you measure a good tear film volume, if you don't have an adequate mucin layer to adhere the tear film to the underlying ocular surface, well, then you're in trouble anyway. So I'm not sure if that answers why it matters whether or not we have 2 or 3 layers, but it definitely matters that we have all 3 layers functioning appropriately.
Thoughts on like a LipiFlow or TearCare or iLux. The lipid layer potentially does a couple different things. It maintains stability by spreading, but it may not be doing exactly what we think it's doing. How critical is the thickness of the lipid layer to maintaining tear film stability? Perhaps is a better way for me to ask that.
I've got to say, it's not going to be my forte, so I don't think I can answer that properly. What do you think, Chris?
I think what they were saying in the TFOS, so what Mark was saying was that the lipid layer isn't as critical to preventing evaporation as we thought 10 years ago in the original DEWS report, where lipid layer was pretty much everything when it came to preventing evaporation, and it was, I think we thought it was thicker back then, and I think in this one we're realizing it's much thinner than we previously thought, and that it's probably only responsible for less than maybe 15-20% of evaporation, and the mucin and mixed mucoaqueous layer is actually very important for preventing evaporation too, and mucin has a much bigger role in that than we previously thought. That's what I think the TFOS DEWS 2 kind of take home, simplified version of that is, but I could be wrong.
Definitely clinically, I will see patients whose lipid layers, with the LipiView again, less than 65 nanometers or less than what's recommended to be average according to recent evidence. And however, they'll still have a stable tear film. They won't have any symptoms. My biography is good. The glands are expressible. So I think that would concur with what the evidence suggests as well.
Did you learn anything along the way that surprised you throughout your experience on the committee?
Definitely. If I was to look back on, I guess, the learnings at the time, it was, I guess, how important it was that the science feeds into the clinical side of things. So we can do all the clinical studies in the world, but they need to ultimately feed into what changes clinical practice, which is why the pathophysiology workshop was so important. It identified the underlying mechanisms that then fed into diagnosis and management. The fact that we have to intervene somewhere in the vicious circle if we are to control dry eye disease.
How about taking us through what were perhaps the key findings and future direction? And what do you think we don't know, right? We just heard Dr. Hermroth say that on our last podcast. What do you think our knowledge gaps are in terms of the pathophysiology of dry eye?
I think one of the areas that we need to expand on is understanding more the frictional impact of dry eye disease and the role, for example, of reducing friction and how that will do to minimizing the propagation of dry eye disease. So I think there continues to be some controversy about, for example, lid wiper epitheliopathy. Some studies indicate that that's associated with symptoms and that is an important indicator of dry eye disease. But there's been some debate about that. So I think we need to establish a good way of evaluating lid wiper epitheliopathy. Is assessment lissamine green staining enough? Are the dyes that we have to evaluate this appropriate? And then once we've established an appropriate way to evaluate it, then establish whether or not friction does cause lid wiper staining and whether that plays a role in the symptomatology and the progression of dry eye disease. So I think that's an example of the sort of thing that we need to understand.
What should practitioners know about line of marks, or what do you do when you're evaluating a patient? And if you can talk to us a little bit about what is line of marks and should we be looking at that on all of our dry eye patients? Okay,
so there's some evidence to suggest that if there's displacement of Marx's line, that indicates that there's scarring of the glands, or basically displacement of the glands. So we will always look at Marx's line to establish how regular it is. We'll also always stain for Marx's line before we debride, so that we make sure we're debriding over the orifices and avoiding the lid wiper area at all costs. So I think it's important to look for Marx's line, both for the diagnostic aspect as well as for when you're treating for with lid debridement.
Can you just describe how you look at Marx's line?
So we'll use lissamine green for this, 2 drops of lissamine green on the bulbar conjunctiva, and then evaluate after about 5 minutes. And we're looking posterior to the orifices and looking at the regularity of it. So how smooth is it? You'd expect it to be just a smooth line. If you find that that Marx's line is irregular, then that would suggest potentially that we've got scarring of the glands or displacement of the glands.
And does inflammation cause hypertrophy of line of Marks, or do you think that's more of a mechanical blockage of the glands that's going on, or what do you think is the cause behind that?
The cause behind displacement of line of Marks?
Line of Marks, right. You said you debride on top of line of Marks, right?
We debride anterior to it. So we make sure we debride over the orifices and not behind where the lid wiper would be.
Wiper, right. And a practitioner once told me he was debriding on lid wiper, and I said, no, don't do that. That's going to be a lot of problems. Chris, is that something you ever look at in your clinic?
Yes, but I probably don't use the right terms for all of these things. I think it's important to stain and then look at the lid margin and the line of Marks and all of those things. I don't think I'm as careful with my debridement, because often when I debride, I'm using something like a BlephX, a microblepharal exfoliation device and that's not fine enough,
so
I don't think,
yeah,
to get to sort of not. Do you just get the base of the lashes and the lid margin in total? So maybe well,
listeners should look up Caroline Blackie's paper from years ago that showed pretty quick reduction in symptoms from patients.
Yep.
So we'll actually debride combined with a tear care, for example, or an iLux. We'll debride, and we know we should automatically be getting some symptomatic improvement right away from doing that. I use a golf club spud personally.
Same. Yeah.
And I'm not super aggressive. I know some practitioners are. I don't know what the right amount is, but you can actually oftentimes see meibum just start coming out right out of those glands once you go on top.
Yeah. Actually, what I didn't say was to go back a few steps. We'll heat up the lids first with, we use the Blephesteam in the clinic. And if that's not available, just a heat pack. And then we'll anesthetize both eyes, topical oxybuprocaine, whatever we've got available. And then we'll soak a sterile cotton bud with the oxybuprocaine and run it across the lower lid margin just to weaken cellular adhesions, and then debride with the golf spud and then express with the forceps. And I'm really picky with the forceps I use. I quite like the Areta, the flat ones, if I'm allowed to say that here.
You are. Do you ever do the uppers?
Yeah. Upper and lower. Upper's trickier, much trickier. It's more slippery, but yeah, we'll always debride upper and lower. You've got more glands in the upper lid, so it can be more satisfying sometimes, just squeezing those out. So yeah, we'll do both. But
it does make patients' skin crawl when you do the upper.
Yeah, they're not happy.
No.
We'll give them some corticosteroids to go home with.
You mentioned Areta, and that takes me to Asia, which you're not too far from. A different look, a totally different view of dry eye disease in Japan versus Australia, based on a quick tear film breakup time, correct?
Yeah, and they've got a different definition, I believe, that they use, and they also have access to secretagogues and drugs that we do not have access to over here, unfortunately. But yeah, different definition used.
Is there much alignment? I know you're geographically a lot closer than we are to Japan, of course, but is there much alignment in terms of dry approach between Japan and Australia?
In Australia, we're very much based on the TFOS DEWS 2 guidelines. So no, we're not using the definition that they're using there. I believe there's a lot of emphasis on the different types of tear breakup as well in the Asian definition, which again, we don't place a lot of emphasis on it clinically over here. But no, it's very much TFOS DEWS 2.
Very good. Chris, you said you took a bunch of notes. Do you have any other questions for us today?
I think it would take me about an hour and a half to read my notes. No, I think we covered a lot of all the important things, I think, in there. I'm sure we could dig in and find a lot more esoteric stuff, but I think this has been useful for the average practitioner. I think the vicious circle really is the key here, and the way one thinks about that vicious circle and all the entry points. I think that's the important thing, and I think we covered that pretty nicely.
Yep.
Maria, any parting words for practitioners who don't read 1,000 pages or 73 pages of the 1,000 references?
Just 73.
Yeah, of the pathophysiology section.
I think I would say, just in terms of the clinical diagnosis, just remember the first step is to establish, do they or don't they have dry eye disease? And then once you've established that, based on either the symptoms or the 3 signs of osmolarity, tear breakup time, or staining. Once you've got a yes or a no to that, then if it's a yes, the next step is to subcategorize. That's when we bring in other tests like, the lipid that we talked about, gland expression, or Schirmer test, and so on, to establish aqueous deficiency. So I know a lot of clinicians get a bit confused about how much testing there is to do with dry eye disease, but I always just like to think of it in those 2 steps. Step 1, do they have dry eye? Step 2, what type of dry eye do they have? Remembering that the aqueous and evaporative dry eye can lie on a continuum. So I think that's my key point, I would say.
Great. Well, thank you so much again for your time. Good luck in the next workshop, and say hi to Dr. Wilcox. You can bang on the wall and say hi to Dr. Wilcox.
I'll knock next door. Fiona's down, just 2 doors down after that. So
good. All right. Well, thank you. Have a very good day, Maria.
Thanks very much, guys. All right. Bye.
Thanks for listening. Join us for our next episode soon. Find us online at www.ocularsurfaceacademy.com, all major podcast platforms, and YouTube.